All right, guys, so I'm going to talk first a little bit about a few things from chapter 22. And since the recording from yesterday's class lecture went a little crazy and recorded in double speed, which I don't even know how it occurred or how to fix it, I'm going to go through and do just a little highlight reel, if you will, on chapter 21. So 22, we talked a little bit about kind of what is blood pressure, what are risk factors associated with the development of hypertension. And so anytime someone has hypertension, they're at risk for cardiovascular disease and stroke. That's going to be directly related to the fact that the vessels are being impacted significantly by the force exerted upon them. So if we're taking our blood pressure and it's high, that means that the vessel wall is being pressed against harder than it should be. So in order to prevent rupture or stretching too far or additional complications, that vessel begins to stiffen up so that it can tolerate the force being applied to it. And as that occurs, it increases the blood pressure because the flexibility of that vessel is kind of what allows it to adjust and accommodate the changes in blood pressure. And as that becomes stiff over age and after exposure, it's going to be less compliant with the changes. And so when that occurs in the vessels feeding the blood supply to the heart, that puts us at higher risk for cardiovascular disease. Same thing in the brain. The blood vessels supplying the brain are small enough that as they are damaged, they're putting us at higher risk for incidence of stroke. And so we talked a little bit yesterday about the kidneys. The kidneys are also involved. We'll put a risk factor for kidney disease because the kidneys receive about 30% of the blood from each contraction of the heart ventricle on the left side. And as that blood is expelled from the heart down through the aorta, and 30% of it goes to the kidney, when that blood pressure is elevated, the force with which the blood hits the kidney is higher than the kidney is designed to tolerate. And it causes a little bit of damage. And over time, that damage begins to create scar tissue, which decreases the ability of that area of the kidney to function. So that's kind of how those areas are impacted by that high blood pressure. And we know that hypertension is a common diagnosis. We see it for so many of our patients in the clinical setting. One thing I do want you to be aware of that may have changed from what your expectations are is the diagnosis of hypertension. And so to be considered normal, you have to be less than 120 millimeters of mercury systolic and less than 80 millimeters mercury diastolic. And if you'll look at page 362 in the upper left-hand corner, you have a table, table 22.1, which gives you a little bit better definition of each one of those stages in that process of hypertension. So we have normal, which is that less than 120 and 80. We've got elevated, which is 120 to 129 systolic and greater than 80 diastolic. I'm sorry, less than 80 diastolic. And then hypertensive is going to be that 130 to 139 systolic and 80 to 89 in the diastolic range. And then stage 2 hypertension is going to be greater than 140 systolic or greater than 90 diastolic. And please notice those values differentiate there with the terms and or. You don't have to have both to be considered hypertensive. One of the two makes you hypertensive, but to be considered normotensive, you have to have both. So please make sure that you evaluate the words and or in that table to verify that you're evaluating that correctly. So hypertensive screenings, I know we discussed this a little bit, and even though we may not necessarily agree with the time frames, these are the time frames that have been established. That you only need a BP check every 3 to 5 years if you don't have any increased risk. But those increased risks kind of affect all of us almost. Those risks are a family history, obesity, a history of hypertension, African-American descent. All of those things are going to lead us to have a higher risk of developing hypertension. And if we do have any of those things, or we're over the age of 39, we have to have annual blood pressure screenings at a minimum. So we did cover this, but I'm going to talk about it a little bit more just to make sure that you guys all have an understanding, since we were a little briefer than we'd planned yesterday. So what we're measuring when we measure the blood pressure is we're measuring the amount of force or pressure exerted on the blood vessels by the blood itself. And so the blood, as it pushes against the wall, applies a certain amount of force, and that force is going to be measured in millimeters of mercury, and that's what we're evaluating. And so our blood vessels are designed to tolerate about 120 millimeters of pressure at the systolic, and about 80 millimeters of pressure or mercury of pressure at the diastolic. But when we exceed that, that alters the function of the vessel itself. And so things that can alter that amount of force being applied to the blood vessel wall is our cardiac output, which we remember is heart rate times stroke volume. So if our volume is the same, but for some reason our heart rate increases, maybe it's been stimulated by the nervous system, maybe we have engaged in some kind of exercise or activity that's elevated the heart rate, but without changing the volume, the pressure is going to increase because the cardiac output has increased. Peripheral vascular resistance. So those extreme vessels that we've talked about that maybe are stiffened or hardened because of age or trauma, as those become more stiff, they're going to be less compliant, they're going to have less flex, and so when the force coming from the blood being pumped out by the heart pushes against that wall, it's going to be a little stiffer, which is going to increase the resistance or increase the pressure there. And there's a little bit more detail about peripheral vascular resistance there on page 362. It gives you a little bit of a definition that the peripheral vascular resistance is the ability of the vessels to stretch, and that stretch is altered, as we just discussed, when damage occurs to the vessels, when they age, things like that. So the vessels stretch, there we go. And then blood viscosity, and viscosity, remember, is the thickness. So how thick or thin is the blood? Obviously, thick sludge-like product is going to take a little bit more work to push through the system than blood that's thin. So that's why a lot of times we discuss with people when they become mildly hypertensive, or if they're beginning to become hypertensive, they may recommend them being put on a low dose of aspirin, like 81 milligrams. And that's just to help with that viscosity. As that decreases, that's going to decrease the force being exerted on the blood vessel walls. And though it's not meant to work as a blood pressure medication or a hypertension medication, it does impact one of the factors that contributes to hypertension, and hopefully reduces some of that work there. And then the blood volume. And blood volume can be related to our intake, our output, our renal function. As our renal function decreases, we're not going to have as much coming out, even if we're taking in the same amount. And so our blood volume is going to increase. And remember, this is our vascular volume. This doesn't count fluid that's in that extracellular or interstitial space. We're only evaluating that intercellular and blood volume that is within the vessels, because those external factors are not necessarily impacting the pressure exerted on the inside of the wall. So we need to look at the actual blood volume. So we just talked about the classes of hypertension. So now we're going to look at the types. We have primary and secondary. Primary is going to be no reason. Their blood pressure is just up. Age-related changes, family history, those kind of things, they just have high blood pressure. Secondary hypertension is, we know what's caused it. The kidneys aren't functioning, or they have a cystic kidney that's decreasing perfusion, and so that's going to back up some of that blood and cause hypertension. They have a disorder that alters the response, the neurologic response to the blood vessel changes, and so they have a constriction issue that remains at all times, causing hypertension. Whatever it is, we can identify secondary hypertension. So most of the patients that you and I are caring for in the clinical setting are going to be patients with primary hypertension, not necessarily a known reason, but it just exists. So we did talk about the fact that hypertension is a silent killer. We don't necessarily have a set of symptoms that occur with that. Our bodies typically adjust to it slowly over time because it does typically rise slowly over time. In the cases where the blood pressure rises rapidly or in response to a medication or an issue, you may have patients who experience headache. They may experience bloody nose because those small vessels in the nares rupture. And then that high pressure system in that area causes that to bleed, and it doesn't really want to tamponade that easily, and so we continue to see bleeding from there. Anxiety because that hypertensive response is causing changes in the neurologic system. That sympathetic and parasympathetic nervous system is going into overdrive. And so our body's going to release some catecholamines in response to that. That's going to cause us to feel anxiety. And then some shortness of breath. A little bit of that's going to be self-explanatory about how hard our heart is working at that time to compensate for this extreme hypertension. But also, if our heart cannot eject the blood as fast as it needs to allow for that pressure distribution, then some of that blood is eventually going to back up, and we may get some of that kind of overfill in the lungs, because the lungs are one of the first places our extra fluid wants to hang out, because it's an empty space to fill. And so they may begin to develop some of that shortness of breath that you see there. So to diagnose hypertension, we're going to take a blood pressure. We can't diagnose this just on one reading, and we're not going to do it by taking one in the right arm and then 30 seconds later, after we've told them their blood pressure is high, take another reading in the left arm. That's not going to be sufficient. So we're going to take these blood pressures about 2 hours apart, or even on separate days. And ideally, we would have the patient do ambulatory or at-home monitoring over a 12 to 24-hour period and report those findings. It's very, very important when making a decision about how to evaluate these at-home or ambulatory blood pressure readings that we're assessing health literacy and verifying that our patient has the capacity to be able to perform this in the correct technique to be able to give us accurate readings, so that we're making sure that we're doing what's best for them. And if they can't perform those and give you the accurate readings that you need, then it's the responsibility of us as the healthcare providers to make sure that we schedule them to come in so that we can evaluate those blood pressure readings and keep up with what we need to do. Some of the other things that may lead us to a diagnosis of hypertension include signs and symptoms that they've experienced, history, family history, risk factors associated with hypertension, heart or kidney disease caused by that long-term change in blood pressure, and current medications that they may be taking. And I know that sounds kind of silly, but you've had patients, and so have I, who've come in. Do you have any health problems? No, I don't have anything. Well, it says right here that you take lisinopril for usually used for blood pressure. Oh, I don't have high blood anymore. I take that pill and it fixed it. And so you may not have the most accurate historian. And so using their current medications can help us to evaluate, does this patient have controlled hypertension? They're still hypertensive, but it's controlled on this medication. And if you just evaluated the blood pressure and it was a normal finding, you wouldn't necessarily document this patient as having a history of hypertension, because they didn't report it and they didn't show it to you when you did your assessment findings. But when you review their medication history and see, oh, they're taking 2 different blood pressure medications, then you can evaluate that a little further to help you with your diagnosis and your nursing diagnoses and care plans. So risk factors for hypertension. We talked briefly about modifiable and non-modifiable. Non-modifiable are things that a person cannot change no matter what. It's going to be kind of born into them. And then modifiable are lifestyle modifications that we can make. So non-modifiable risk factors: family history of hypertension, age, race, ethnicity. These are things that we cannot alter. They are the way we are born. On the other hand, we have modifiable risk factors like our lifestyle. We can exercise more, increase our physical activity, weight control, manage our diet by reducing our sodium, eating a healthy diet in general, which is going to also impact our physical activity and weight loss. And then managing our blood sugar if you have diabetes, and and you also have high blood pressure, you're at higher risk for additional complications. Or if you have diabetes alone, you're at risk for developing high blood pressure because of the changes that the blood sugar does to the vessel walls. So managing your blood sugar is also going to reduce your risk of developing hypertension if you don't already have that issue. So some treatment for hypertension. Number one, we want to encourage lifestyle changes or lifestyle modifications. The things that we just discussed: weight loss, dietary modifications, increased physical activity, whatever we need to do to try to prevent the use of medications. Unfortunately, a lot of times people are either unable to or not willing to make lifestyle modifications, or because of a strong genetic component, no matter what lifestyle modifications they make, they still remain hypertensive. And so at that point, we're going to need to go on to some medication management. So initial drug therapy, that means things that are typically prescribed first to try to treat hypertension, are going to be thiazide-like diuretics. And so you have a table 22.3. It covers a couple of pages beginning on 364 and running through 367 with a bunch of information about medication classes. And we're going to talk about these a little bit more in detail. So the thiazide diuretic increases urine output, increases sodium excretion. And so that's going to focus a little bit more on the fluid status right there. So obviously you have to consider, A, is this appropriate for every patient? And the answer is going to be no, because if it's not a fluid retention issue that's causing this patient to be hypertensive, it's a vascular issue or heart issue, giving this medication for fluid retention or excreting additional fluid and sodium is not necessarily going to be the most beneficial. So, but if your patient is prescribed a thiazide diuretic or any diuretic for that matter, things that we need to talk about is making sure that we're monitoring I's and O's, or that they're monitoring I's and O's. Seeing when this causes urination. For some people, if the medication takes 6 hours to work, they may want to take it as soon as they wake up. That way they'll pee frequently from lunchtime to bedtime. I am so sorry, guys. I'm sorry. They'll pee frequently between lunchtime and bedtime, and that way they're not going to be getting up all night to pee. If someone, it takes 12 hours to work, then they do need to take it right before bed. So important things to evaluate with those diuretics are onset times and peak times, and then as well as how it impacts that patient specifically, because we can always adjust the timing to meet that individual patient's needs. And then we want to evaluate electrolytes, because like I just said, if sodium is being excreted at a higher rate, then we're going to need to evaluate this patient, especially the first several months that they're using this medication, to make sure that their electrolytes remain in balance so that we don't negatively impact other aspects of cardiac function like we talked about yesterday. So one of the teaching points it has listed here is that we take during waking hours to prevent excessive urination during sleeping hours, increasing our patient's risk for falls. So please keep that in mind when we're looking at those thiazide diuretics, or any diuretic for that matter, because there's a couple of different ones. There's loops and potassium-sparing diuretics, and we can talk about those a little bit more in detail as well. Then we have ACE inhibitors, or angiotensin-converting enzyme inhibitors. So we talked yesterday about that renin, aldosterone, angiotensin 1 and 2, and that process of enzyme development to increase the blood pressure by kind of holding on to some of that that fluid and that sodium. And so here we have something that's doing the exact opposite. As it shows you here, it's saying that we're going to inhibit that. And so if we're inhibiting that angiotensin converting enzyme, we're basically stopping that process of conversion from angiotensin 1, angiotensin 2, and inhibiting the ability to absorb that sodium and hold on to that fluid. And so we're not necessarily forcing the person to excrete urine, but we're kind of pausing their body and pausing it from doing what it is intended to do, so that we can keep them on a more basic maintenance level. So when we're looking at those ACE inhibitors, those are always going to end in pril, like the medication's last 4 letters are PRIL. And one of the primary concerns about those is that they have something that can happen that's very odd, and it's called angioedema. It can occur kind of at any time. It doesn't necessarily have to happen like the first time they take the medication. It can occur anytime during use. And the person may have been on it for 5 years and suddenly they wake up with their mouth and face and throat swollen. And that's a medical emergency. So when we're educating our patients on ACE inhibitors, we always want to talk to them about angioedema and the fact that it can cause swelling of the throat, that it can happen anytime, and that it does require emergency management. So if they have that happen, they need to seek help right away. We also want to talk a little bit about using sunscreen with our patients because it does make them a little bit more sensitive to light. And then lastly, we don't want to cut this medication off quickly because their body is, still going through the motions of that conversion process, and we've inhibited it. So if we just stop this medication, the body's going to continue to do what it's been doing, and now the patient's going to end up with something called rebound hypertension. They're actually probably going to go higher than they would be normally in response before their body realizes, oh, wait, I've got too much, I need to stop, because it will take a little bit of time for that recognition to occur through those chemoreceptors and baroreceptors that we've discussed, impacting the neurologic system. So then we have angiotensin II receptor blockers, and that's going to be a similar concept. It blocks angiotensin II, causing the blood vessels to dilate, which is going to reduce our blood pressure. So with that angiotensin, we talked about vasoconstriction, and now we're talking about this forces that vasodilation, which is going to cause that change in blood pressure. And so with calcium channel blockers and those angiotensin II blockers, that vasodilation occurs. And our primary concern when we have that onset of vasodilation is orthostatic hypotension, because we're given a medication that tells this vessel, open up bigger, which is going to reduce the blood pressure because we have more space for the volume to flow through. But our bodies typically feel that change in pressure from those baroreceptors when we go from one position to another. And when that is being inhibited by medication, the response time slows. And so our body naturally will respond at a specific rate. But when we have this medication, that response time decreases. And so we will respond to change in position, but it's going to take more time. So when we educate that patient, we want to talk to them about dangling their legs on the side of the bed before standing, rising slowly, making sure that they have something to hold on to when they stand up for those first couple of seconds before they try to take a step, so that they have time to verify that they're not dizzy or disoriented, and if they are, to sit back down. And all of this is really just about fall prevention. The last thing we need is to complicate someone who's already got some health comorbidities going on by adding a fall to that. So a few other things on there that you can talk about are those vasodilators that we talked about, the hydralazine. You have combination medications, which is maybe going to take like a thiazide diuretic and maybe a beta blocker or something like that, and they're going to put them together to work on the patient's blood pressure. And then we have, I'm going to erase what I just wrote for you guys. So we talked about the diuretics, we talked about ACE inhibitors, we talked about calcium channel blockers, we talked about the alpha blockers, or we didn't really talk about those, we'll talk about those now. So the alpha blockers, they block the sympathetic nervous system's response. And so we know after so much of our conversations in neuro about the sympathetic and parasympathetic response and how that's going to increase and decrease our heart rate. So if we're taking a medication that alters that nervous system response, then we're at risk for tachycardia. And then the beta blockers are really working in the exact opposite way. They're working on the sympathetic nervous system, resulting in a decrease in blood pressure and, more importantly, a decrease in that heart rate. And so beta blockers are always going to put us at risk for bradycardia. So anytime we want to go administer those medications, it's important to evaluate the heart rate prior to administration to make sure that we're doing that in a safe environment. So that aspirin, 100 milligrams, I don't like that term, and I'm not going to tell you not to use that, but I don't particularly like that because Aspirin typically comes in 81 milligrams or 325 milligrams. And so to take 100 milligrams at bedtime is a little bit troublesome for the patients because it can be extremely expensive trying to buy a customized dose, where 81 milligrams is affordable and it's advertised there as heart health, and it's something that patients can easily assess. So, you may want to have that conversation with your patient about what they have the ability to access affordability-wise, and it may be appropriate to discuss that with the physician about switching that to 81 milligrams. So just consider that, because that is going to alter that blood viscosity that we talked about at the very beginning that's going to impact hypertension kind of in a roundabout way. It's not directly involved in altering the blood vessels or the blood pressure itself, but in the viscosity, which does impact that. So some of the complications of hypertension that we discussed and will continue to discuss over the next couple of days and even weeks as we use this cardiac information on some of our other courses is that atherosclerosis, the hardening and thickening of those vessels, the coronary artery disease. We talked about here at the very beginning, those vessels become impacted by the changes in pressure and become stiffer, making them less compliant and easier to allow for clot formation, which is impacting the myocardium or the muscle of the heart. A heart attack itself, all of those things that we just described about the blood vessel is now at higher risk for developing that heart attack. Heart failure, as the blood pressure continues to rise over time, the muscle has to stretch to accommodate that. It can only stretch to a certain point before it becomes weak and floppy, or before it becomes thick and hard. And either way, the compliance and the ability to force out the volume of blood that we want, remember that 55 to 70% ejection fraction, the volume that we actually expel from the left ventricle with each beat of the heart, which is like 60 to 80 milliliters, is not able to occur because the muscle itself has changed. And when that occurs, it will continue to back up into each atrium or ventricle or space before that, lungs, and eventually back up into the lower extremities. And that's going to result in heart failure over time. That risk for stroke, two different types. We have a risk for a clot to develop because the vessels are non-compliant, stiff and hard and small and narrowed, and have a place for things to kind of develop and cause a stroke. Or the exact opposite, depending on the level of hypertension. If it's extreme, those vessels may actually rupture and cause a hemorrhagic stroke or a bleeding stroke there in the brain. And then kidney and eye damage. I talked fairly extensively about how the kidneys are impacted at the beginning, but the eyes are the same way. There's small blood vessels supplying the eyes, and as the pressure increases in there, it's going to damage the blood supply to the eye, number one. And number two, it's actually going to increase the pressure inside the eye, which can alter the shape. And if you go back to our sensory lecture, we talked about that spherical shape. And as the pressure being applied there changes, it can minimally alter that shape, which is altering the visual field there as well. And then a hypertensive urgency. A hypertensive urgency is going to be classified with a blood pressure of 180 or 120 diastolic, 180 systolic. And this person may have headaches, nosebleeds, shortness of breath. The only difference is that they don't necessarily actually end up having a heart attack or a stroke or an aneurysm or a problem with their abdominal aorta. But they don't have an organ that has become dysfunctional immediately in response to the blood pressure. But it does require immediate intervention to control it. Usually that's going to be done with IV antihypertensives. And it's done on an inpatient setting so that we can slowly bring that patient down so that we don't have any rebound issues. And remember, if this person's been living at this high level of blood pressure and we bring them down to normal rapidly, that patient's going to kind of feel like crap because they're going to have decreased perfusion until their body has time to adjust to that. And so they're going to feel really bad and may experience dizziness and lightheadedness even at what we would consider to be a normal blood pressure. So we do want to control that and implement treatment right away, but we want to do that in a kind of paced environment. We don't want to make a rapid change. And the difference in what makes a hypertensive urgency to an emergency is that there is an organ that has become dysfunctional, like the heart, the brain, the aorta. Something has been impacted, and we're going to immediately go ahead and begin IV medications to reduce that. Nipride or nitropres is one of the options. There's a few others. It depends on the physician's order. But familiarizing yourself with that medication prior to administration is imperative for your safety and the patient's safety to make sure you're doing what's best for them. So some of our nursing diagnoses: readiness for enhanced health literacy. That goes back to what I told you just a few minutes ago. We need to make sure that before we go and ask this patient to do this, that they're prepared and have the ability to do that. If they don't, then are they receptive to allowing you to work with them to improve their health literacy and make them a little bit more prepared to manage that care, which leads us to our second diagnosis, the ineffective health management. Maybe they weren't willing to make the lifestyle modifications, or maybe they made those, it was ineffective, we put them on medication, but because they felt better, they quit taking their blood pressure medication. So ineffective health management, they're either not understanding or they're choosing not to do that with one of those two diagnoses. And then risk for unstable blood pressure, of course, because it's not like the first pill that's prescribed to a patient is a magic cure and it works perfect for them. Those things have to be evaluated and adjusting on an ongoing basis. And so they're always at risk for unstable blood pressure, especially while you're in that initial treatment phase, finding out what medication regimen is going to be best for that patient. What else do we have here? Patient education, lifelong blood pressure control is necessary. I understand that people don't understand that because their blood pressure is normal while they're on blood pressure medicines, that they are not cured. So you need to make sure that you're educating the patient to say that this medication may bring your blood pressure back to what we consider a normal range, but that doesn't mean you don't have high blood pressure. It means the medicine's working. And that is something that I assure you you're going to encounter at least with one patient before this is over with. They're going to tell you they don't have diabetes anymore. They don't have high blood pressure anymore because they took this pill and now it's normal. And they are right. They are back in that normal range, but it's only because of the medication management. So making sure that you're providing education on the necessity of lifelong care, lifestyle modifications, and then using the medication regimen as prescribed, not however they feel like is important. So dizziness. Dizziness may increase risk of falling. Rise slowly to prevent orthostatic hypotension. We discussed that. And more importantly, after discussing kind of what we're going to do to prevent orthostatic hypertension, how are we going to diagnose orthostatic hypertension? So please make sure you review that chart that we discussed yesterday face-to-face about how to properly take those blood pressure management, where the arm needs to be in relation to the body, the position of the patient, things that they should do and avoid before taking that blood pressure measurement, and how often and how frequent are we going to use that, and then how to properly place the cuff and size the cuff. All of those are absolutely necessary to ensuring that we can manage that patient's care appropriately. So please review that box. And then also the one right below it on orthostatic hypertension, how we're going to take those measurements to ensure that we can see if this patient is having a rapid change in blood pressure. Do we need to notify the physician to maybe make a change to their regimen to keep the patient safe if they are at risk for falls and are confused? Or do we need to spend a little more time educating the patient on ways to prevent that from occurring, like letting the feet dangle, standing slowly, using an assistive device until they have their balance, those kind of things. So we'll go through these real quick, review questions. Cause of primary hypertension. Nobody knows, right? We don't have an understanding of that. The nurse would include which of the following as modifiable risk factors. So when we think about this, what is modifiable? Modifiable is something we can change. Can I change my age? No. Sometimes I think we lie and pretend we can, but we know we really can't. Can I change my diet? Sure. Do I want to or am I willing to? Maybe, maybe not, but I have the ability to. Can I change who my family is? If y'all are like me, sometimes you might consider it, but it's not something we can actually do. Glucose control. Can I manage my blood sugar? Absolutely. I can take my medications that I'm supposed to. I can modify my diet so that I don't eat foods that are going to elevate my blood sugar, things like that. And then weight control. If I do some of the things that are suggested here, like modifying my diet, modifying my blood sugar, then I'm probably going to impact my weight subsequently. So can't do age, can't do family history, but I can modify my diet, my blood sugar, and my weight. So nurses contributing to the plan of care for a patient with new hypertension who is requesting information on how to manage that. Which of the nursing diagnoses is appropriate? So increased cardiac output. Yeah, they probably have it, but does that have anything to do with what the patient's asking? Because the patient's asking you how to get information to manage the hypertension. So no, that's not appropriate. Ineffective health management. Well, maybe, but is it really ineffective if they're asking you for information on how to improve it? I'm going to say no. Ineffective coping. Well, I feel like they are coping. I think they are coping because they're asking you, again, requesting information on how to manage this, which indicates they have a desire to participate, so they are coping. We have readiness for enhanced health literacy. Yeah, this patient is obviously ready for that because they're asking for information. So evaluating that information, I would choose question 4, because I feel like the patient is saying that they're ready for that, where all of these things are a negative, the patient is not there. An increased cardiac output we can eliminate because that has nothing to do with education or information. Now let's see what they say. Let's see if they agree with me. Look at there. The nurse evaluates the patient, understanding teaching if the patient states hypertension must be managed for which time frame. So how long do we have to manage blood pressure for? We just covered that there at the very end. That's a lifelong management. If your patient says any of these other answers, they're going to require additional education. What should the nurse include in the patient teaching plan to prevent falls when taking antihypertensive? Lord, if you don't get this, you're in trouble, because I've said it at least 3 times in this lecture. Do we sit at the bedside when changing positions? Absolutely. I told you to sit there and let your legs dangle. Rise slowly when standing. Absolutely. We want to give time for those baroreceptors to scent change. Send that information through those afferent neurons to the brain, where they can then respond and send back a signal to change in response to those efferent neurons. So we're going to allow that to occur. If they're dizzy, sit down. Of course, the last thing we want to do is keep standing and wait and fall. Stand up quickly. Well, I can give y'all a little test taking tip right here. We have one that says stand slowly and one that stands quickly. Can they both be there? No. So you know one of these answers is incorrect, and you can eliminate it from your possibilities. And we know that we want to go slow. So even if you weren't sure, you would know it has to be one of the 2 is correct, because they're opposites. And so you could try to evaluate these other components and how they impact. And then request assistance to stand if a history of falls. That's appropriate for every patient. If someone has a history of falls, we want them to ask for assistance every time. That's why when we walk in, you say, call before you get up. Here's your call bell. Make sure you call me. Don't get up by yourself. All of those things are to prevent this, right? So everything except stand up fast. All right, so that covers a good bit of the information from hypertension. I'm sure you may have some additional questions, and if you want to come in and discuss anything with me about those additional medications on that chart in 22.3, I'll be happy to discuss those with you. If you have questions about them that you want to discuss as a group, please feel free to email me and add those to the discussion forum, and I'll be happy to try to answer those the best I can for you. I think one of the most important things is to identify, those last couple of letters. Those are really going to help you to see what medication class that is. Like I said, those LOLs, metoprolol, latenolol, labetalol, everything that lands in lol is going to be a beta blocker. Prills are almost always going to be those ACE inhibitors. The Pines, P-I-N-E, those are almost always going to be calcium channel blockers, and some of those are your most frequently used classifications. So no, you cannot remember everything written down in the calcium channel blocker list. No, you cannot remember all those meds. But you might remember that something that ends in Pril is an ACE, and ACEs make us think of angioedema, right? So if you were going to educate your patient, what would you do? So try to highlight those important pieces. I know you can't memorize them all, but highlight those important pieces. And if you have questions, let me know so I can make sure that you are highlighting the correct information and not trying to memorize something that's not going to benefit you in coursework or in practice. So review that, use the discussion forum, email me, reach out. I'll be happy to help you, but you got to let me know what you need.